Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. I'm Todd Schlosser, and today my guest is Dr. Khaled, a neurosurgeon at Hartford Healthcare. In this conversation, we discuss his path to becoming a doctor that literally took him around the globe. We also discuss deep brain stimulation, exactly how it works, and some of the amazing innovations that are coming to that space. Enjoy the conversation. Dr. Khaled, thank you so much for joining us today.
Thank you for
we appreciate it. I'd like to start off a very similar way I start off most of the podcast, and that's simply, what was it that made you want to pursue a career in healthcare to begin with?
Just looking at, when I was in high school, I was looking at different careers, obviously, and trying to decide what am I going to do with my life. And I really felt that the thing that comes to me the most natural way is helping people. Mm-hmm. And being there and being selfless. Mm-hmm. And I think medicine was the career that mostly embodied those principles and values that came to me naturally.
Yeah. So was there someone in your life that sort of looked for you or sort of guided you to pursue medicine, or was it just you were?
My father was a very strong influence. He's a diplomat.
Oh, okay.
But he there were no physicians in the family.
Yeah.
And I was his oldest son, and so he encouraged me in that direction.
Awesome.
Yeah.
So, and you sort of had an interesting upbringing, maybe not interesting to you because you lived it, but interesting to me, someone who grew up in the States. You grew up in Egypt, I believe.
So I'm Egyptian, but I grew up in a lot of different countries, given the fact that my father was a diplomat.
Yeah.
So my childhood, I actually spent it in Zimbabwe.
Oh, wow.
And then my teenage years, I was in Bangladesh.
Okay.
I was in British schools throughout that time period. So it was an interesting way of learning English with a British accent at school, and then a mix of Middle Eastern accent at home, and African accent in Zimbabwe and an Indian accent in Bangladesh. I don't know what kind of accent I have now, but
it's sort of a hodgepodge. But yeah, it makes it work. But you went to med school, I believe.
Yes,
in Cairo,
went to med
correct?
school in Cairo, Egypt. Yes.
So was the family there, and you just applied to schools there, or did you seek that out? Or
yeah. So the way it works in Egypt is there is no pre-med. You just go take the national high school test.
Okay.
And then if you rank within the top 5 percentile, then you can choose to go to medicine.
Oh, okay.
Which is what I did.
Sure.
And med school there is 6 years rather than 4 years.
Okay, so it's a more arduous program, perhaps, because it's sort of bridging the gap between, I guess, like the prereqs you would do in regular sort of Bachelor's of Science degrees.
Exactly.
Yeah.
Yes.
Okay. So because you did come to the States for your residency, correct?
So I did. So I finished my med school in Egypt in 2000, and then I did my internship and neurosurgery residency there.
Oh, okay.
Completed my neurosurgery at Ain Shams University in Cairo, Egypt.
Okay.
And finished that in 2005.
Okay.
And then I came to the United States 2005 and did a couple of years of fellowship at the Cleveland Clinic.
Oh, okay, so you actually did your residency in Cairo as well, and then came here for a fellowship.
Yes.
Okay.
And that's kind of the back door of entering neurosurgery residency for foreign medical graduates like myself. You have to prove yourself in research or a fellowship or something of that sort before you apply for residency again. To become board certified in the United States in neurosurgery, you have to do your full residency here.
Okay.
So regardless of how much training or how much practice you've had elsewhere,
right.
It only counts for a few months. So you have to do the full training here.
So is that process difficult? I mean, clearly it's a time commitment.
Yes.
But is the process of like applying to come over, is that difficult? Or
yes, there's lots of steps and there's a lot of competition, so you have to prove yourself.
Yeah.
So after doing a year of pediatric neurosurgery fellowship at the Cleveland Clinic and then an epilepsy surgery fellowship, I was in the process of applying for residency. So in terms going backwards, because fellowship is after residency.
Sure, normally it is, yeah.
And I got into residency at University of Virginia.
Okay.
I spent 6 years there. And then I did a year of informal fellowship at Somerset, Kentucky, at the Lake Cumberland Neurosurgical Clinic there with Drs. El Nagar and Dr. Okolini. And then I did my chief year at the Detroit Medical Center.
Okay.
My training spanned from 2001 to 2015. So 15 years of training after med school.
Yeah. That's clearly all doctors go through a lot of training, but that's a lot for doctors.
Yes.
Yeah.
And then from a neurosurgical perspective, to become board certified, you still have to start practicing for a few years, get in some cases, and then submit the cases to the board.
Okay.
They review the cases, and then you take your oral board exam.
Right.
So from the time I started my neurosurgical training in 2001 until I became board certified in 2019, it was a 19-year process.
Oh, wow. Yeah.
Around 100,000 hours of work and studying.
And they say it takes about 10,000 hours to become a great at something. So
yes.
You've done 10 times that, so congratulations. I would like to back it up a little bit and ask you what it was that drew you to neurosurgery originally. Because, being a doctor could be any number of things. But
yes.
You focused in on neurosurgery.
Yes. So in the beginning, I knew it was going to be a surgical specialty, not a medical specialty.
Okay.
I like to do things with my hands. I want to see the results. And then it was a choice for me, interestingly, between obstetrics, gynecology on one hand and neurosurgery on the other hand.
Oh, wow. Okay.
Two completely unrelated, unrelated specialties, but that's how it was for me. And the potential in neurosurgery was much higher, and that's what drew me to it.
When you say the potential for it, do you mean innovation as far as technology and techniques?
Our understanding of how the brain functions and what we can do with that, techniques, innovation in terms of technology, that was clearly more promising in neurosurgery than any other surgical specialty.
You sort of did 2 residencies.
That is correct.
So one in Egypt and one here. When you went through your fellowship here and then had to reapply to residency and go through that again, was that a strange process to be a day one resident, year one? With all the training you already had?
Every training and every place I go to, I learn something different. And I was looking at it from that perspective, is that I've learned the basics, but there's a lot more to learn.
Sure.
And having had a little over 30 mentors throughout my career until this point, taught me that there's always something new to learn, and there's always a different way of doing things.
Yeah.
And the more I learn, the more broad experience I have, the better experience I can give for my patients. So one of the things that I always take into account when I'm making a decision for one of my patients is a few things. One of them is that a patient is not just a medical condition. They are a human being who has a social life, who has a background that I have to take into account when I'm making a decision for them. So maybe their ideal option would be a major surgery, but their social situation would not allow for that. So what can I do to fit that patient's special condition or situation as a human being who has a social life into his medical decision-making process? So I don't rubber stamp decisions or because it says that this should be done that way, that it has to be done for everyone. So I try to personalize basically the care I give to my patients, and having a broad range of experience and having learned different ways of doing things really helps make me do that in an easier way and provide that service to my patients.
Yeah, and I think it's telling of sort of your nature as a person that you embraced that going through residency again as just a way to learn more and a way to get better and hone your skills.
Definitely, and even after residency, I still continue to learn and teach myself.
Yeah.
And actually, I was talking to one of the neurosurgeons who is one of the big names in the country in a course, and he was telling us that currently in his practice, he is applying 0% of what he learned during residency. And all what he's doing now is what he taught himself and learned after that.
Sure.
So it goes to say that learning and improving oneself and improving one's skills is a continuous process that does not end with residency or fellowship.
Sure, absolutely.
It's something that one has to continuously pursue throughout your career until you stop practicing.
Yeah, I think anyone in any field, in order to be successful, has to be a lifelong learner.
Yes.
They can't sort of rest on their laurels as it is. They have to continue to push forward and move forward and just better their skills at whatever they're doing.
Yes.
So it's clearly you've done that, taking almost 20 years to sort of transition from one country to another. And I've talked to a perfusionist that did sort of the same thing.
Okay.
He went from India to Toronto to New Orleans,
Okay.
and he had to go through school again.
Yeah.
And he, like you, looked at it the same way. It's an opportunity to learn more and be better.
Yes.
And I think that's the right way and the best way to look at it. So I heard you mention that you went to the Cleveland Clinic for one of your fellowships.
2 of them, yes.
Oh, both of them were there?
Yes.
Okay. So how many years were you at the Cleveland Clinic?
2 years.
Okay. They are normally a year, but residencies can vary. That's right.
Yes.
Okay.
Residencies is now it's officially 7 years. It used to be some programs were 6, some were 7.
Oh, yeah.
But it's now 7 years.
Yeah. Does that include a research year?
It does include. So
Okay.
while I was at the University of Virginia, I did research in focused ultrasound.
Okay.
I was involved in that. And that's a non-invasive way of making lesions in the brain for the treatment of different conditions. Currently, it's FDA approved for lesioning for essential tremors and tremor-dominant Parkinson's disease.
Okay.
But there's a lot of research looking at it for lesioning for tumors, lesioning of blood clots, and so forth, and breaking down the blood-brain barrier for drug delivery and so forth. There's a lot of promise for that technology to kind of perform a surgery without a knife, basically.
Yeah, absolutely. Because when you're going in, especially on the brain, it's introducing a knife to that situation can be very dangerous.
If you know what you're doing, it's okay.
Well, no, but you wouldn't want me doing it. I'd rather have you because you had so much training doing it. But yeah, absolutely. So anytime you can reduce the risk of a bad outcome,
yes,
you want to be able to do that.
Yes,
So,
and the less invasive, generally speaking, I can't say that applies for everything, but the less invasive, the safer, generally speaking.
Yeah.
But there are situations where you have to be more invasive than others. Otherwise, you will be compromising the care.
Absolutely.
At least given the state of technology and skills that we have at this point.
So you did 2 fellowships at the Cleveland Clinic.
Yes.
Now, when I think Cleveland Clinic, I think Toby Cosgrove and cardiology.
Yes, he was the CEO when I was there.
Okay, so you're familiar with Toby, yeah.
Yes.
Yeah. I had the chance to see him speak once, and I've always been very impressed with Toby Cosgrove.
Yes.
But one of his points in his speech was that when he went from sort of surgeon to CEO, he was not at all prepared for that. And I found that very interesting that sometimes we just jump into things that we're not necessarily prepared for.
Yes.
And we just immerse ourselves in them and we can get through it.
Yes.
So I wonder if your fellowship at the Cleveland Clinic was at all like that. And you did 2 fellowships there.
Yes.
So what was the first one focusing on?
It was pediatric, so it was treating children with neurosurgical conditions.
Right. And
my mentor was Dr. Mark Luciano, and there was a lot to learn there.
I'm sure.
And then the following year, I moved on to epilepsy surgery with Dr. Bill Bingaman. And there was a whole different things to learn from that standpoint.
I'm sure.
Given that they had one of the biggest epilepsy surgery programs in the country, in the world.
Yeah.
So that was a very, very good experience for me.
Absolutely. So I've heard that when you're doing, anything really, you want to get as many repetitions as possible.
That is correct.
It being one of the higher volume centers, you probably got an opportunity to sit in or lead quite a few surgeries.
That is correct.
In those, it was the epilepsy.
Epilepsy surgery, yes. And that's one of the reasons I was hired here at Hartford Hospital is the epilepsy surgery program was greatly expanding, and we are turning it into a level 4 epilepsy center.
Okay.
So I was hired for that purpose, in addition to deep brain stimulation, which is my other subspecialty.
Yeah.
I still continue to do everything in neurosurgery, from brain tumors, spine tumors, degenerative disc disease, spine deformity, and so forth. But in addition to that, I am subspecialized in deep brain stimulation and epilepsy surgery.
So when you leave your fellowship, where did you decide to start practicing? Was it private practice? Was it more of a hospital group?
So I finished my chief year residency at Detroit Medical Center in 2015. And during that year, what I was looking to is not join an established functional neurosurgery program, which functional stands for deep brain stimulation, epilepsy surgery, and pain treatment.
Okay.
But I wanted to establish my own program somewhere where they wanted to build it from the ground up.
Okay.
So hence I took my job at Bay State Hospital in Springfield, Massachusetts.
Yeah.
Because they did not have a functional program there yet, and we're looking to establish one.
Right. And you introduced deep brain stimulation there, is that correct?
That is correct. So before I went there was no deep brain stimulation done at that hospital. And I was trained on using something called a frame-based deep brain stimulation.
Okay.
And I was given a zero budget to start that program over there.
It's always that way.
And so I had to figure it out for myself.
Sure.
So I looked I called one of my mentors in Kentucky and asked him, what should I do at this point? And he guided me, and I sought out a company based in Maine that does frameless DBS. So I went to the factory, saw how they manufactured their equipment and what it was based on. And I taught myself how to do frameless deep brain stimulation.
Can I ask what the distinction is between frame and deep, or frame and no frame?
So the frame, basically, the frame is mounted on the patient's head the morning of the surgery.
Okay.
And then they undergo a scan with the frame on board, and then that scan is then fused with they undergo a CT scan, and then that CT scan is fused with a priorly done MRI. And then the surgeon plans where the target is going to be and where the entry point is, and hence the trajectory,
right,
to avoid hitting any of the major structures and so forth.
Sure.
And once that plan is made, then the coordinates are dialed into the arc that is attached to the frame, and hence the targeting is done.
It's probably a lot more accurate.
It is very accurate.
Yeah.
It is with millimeter to sub-millimeter accuracy.
Wow. Okay.
The frameless system that I used, I implant small screws in the patient's head in the office, very tiny incisions. Screws are like 5 millimeters long.
Oh,
barely,
wow. Very short.
Very tiny. And then the patient gets the CT scan and then goes home.
Oh, okay.
For 9 days or so.
Okay.
9 to 10 days. And I take that scan and fuse it with the MRI and then make my plan. And then I send that plan to the company, which 3D prints that platform.
Oh,
and
okay.
then it ships it over to us at the hospital, and then the patient comes in for the surgery. So instead of the patient having the frame fixed to their head, getting the scan, waiting for the plan to be done by the surgeon, and then starting the surgery.
Having the frame on their head the whole time?
Exactly.
Oh, I didn't realize they kept it on.
They kept it on throughout the surgery too.
Okay.
This is I divide it into 2 steps, so that way the patient doesn't have to wait for me.
Sure, yeah.
The patient's at home. I'm doing the plan at my own time too.
Right.
So if it's a little bit of a more complicated anatomy, I'm not rushed through it.
Sure.
I take my time doing that. And then the day of the surgery, it shortens the surgery a lot, because the patient comes in, we're already done with the planning, we're already done with the targeting, we're already done with all of this. All we have to do is start the surgery.
Right.
So I've taught myself how to do this, and since then I'm not going back to frame based. It's just easier for the patient.
It sounds like a better work-life balance for you, but also a patient balance of not having to have the frame on their head.
Yes, and the frame based, the patient's head is fixed to the operating table at all times, and it's an awake surgery, so not very comfortable.
Yeah.
Not very comfortable feeling. The frameless, the patient can move their head. They can tell me, hey, I want to move my head now, so I stop what I'm doing. They can adjust their neck or head, and it's a plastic, very light platform that they don't feel, versus a metal frame that is fixed
Probably
to the
pretty
bed.
heavy. Yeah.
Yes.
These surgeries can be sometimes pretty long, correct? I mean,
for deep brain stimulation, I keep my surgeries, if I'm doing both sides, under 4 hours usually.
Oh, wow. Okay.
I've done them in 2.5 hours at times. I don't rush through surgery, so I tell all my patients, this is not a race.
Yeah.
I never give a certain set amount of time. I give a range, and I tell them if it takes longer, then it needs to take longer, then I'm going to take longer to do it. The main goal is to do it right and do it safely.
Absolutely.
So I'm not in a race, but generally speaking, the shorter the surgery, the safer it is in terms of the less chance of an infection,
right?
Less chance of bleeding and so forth,
right?
But definitely, I'm not in a race.
Yeah. So when you went to start that program, I mean, you specifically sought out a program that you could build.
Yes.
Right. Does that come from any sort of place of you wanted to build something that you can put your name on, or is it more just you like the entrepreneurial nature of building something from the ground up? What was it that made you seek that out?
I had a vision that I wanted to enact myself.
Okay.
And having trained under a lot of different mentors taught me there are a lot of different ways of doing things.
I'm sure that's true.
So I wanted to use that experience and expertise to build something unique, something that I see will use all what I've learned, instead of walking into a program that's already established where they're doing things a certain way.
They already have their policies,
which I know can be done a little bit differently.
Right.
So that's where I was coming from.
Yeah, absolutely. Obviously, you saw the benefits of deep brain stimulation early on.
Yes.
So do you mind if I have you run through what some of those benefits are and what sort of patients can benefit from them?
Yes. So currently there are uses for deep brain stimulation that are FDA approved, and there are so many others that are still under trials and not FDA approved, although in Europe there are used way more frequently than they are in the United States, because in the United States you have to get the FDA approval.
Sure. Yeah.
In Europe they have a little bit of a different process that is more lenient than here.
Okay.
So from the FDA approved uses of deep brain stimulation include Parkinson's disease, essential tremors, which is another disease which is another movement disorder. It's not as famous as Parkinson's disease. because more famous people have had Parkinson's disease, but actually it is twice as common
Oh, wow,
as
really?
Parkinson's disease. It's just not many famous people have had it.
Yeah, I hadn't heard of it until I started talking to some neurosurgeons.
Yes.
I'd never heard of it.
No, essential tremor is twice as common as,
okay.
as Parkinson's disease. There is also dystonia, which is much more rare. There is something called humanitarian device exemption, which is kind of a little bit of a special use of it that is also FDA approved for obsessive compulsive disorder.
Mm-hmm.
And we're in the process of doing our first patient here at Hartford, DBS
awesome.
for OCD. So these are the ones that are currently FDA approved in the United States. There are other uses of deep brain stimulation that have been done in trials and have shown kind of mixed results, where some success and some failure, including deep brain stimulation for chronic pain, different types of pain syndromes, like thalamic pain syndrome. There is also deep brain stimulation for depression. And actually, there are some YouTube videos on by CNN that show patients in surgery having deep brain stimulation for depression, where they turn from someone who had been depressed for many, many years, have not smiled or laughed in years, smile and laugh in surgery when you turn on the stimulation. There's also looking at it from a schizophrenia aspect. Is it going to work for that? Anxiety. So many different possibilities. Obesity, addiction.
Wow, really? Wow.
So it depends. I mean, we can reach anywhere in the brain with the electrode that we implant, and all it takes is for us to know what the circuitry is, what are the different areas of the brain that form the circuitry. So there are different circuitries in the brain. There are circuitries for movement.
Sure.
If you have a problem with that, then you develop one of the movement disorders.
Right.
Circuitry for memory. If you develop a problem with that, then you develop something like Alzheimer's disease. There's also deep brain stimulation for that.
Absolutely.
In trials. If you have a problem with the circuitry responsible for mood, then you develop depression and so forth. So what we do is with deep brain stimulation, we target different parts of the circuitry and either stimulate that area to function more or run a current that would suppress the extra signals that are being sent in that specific target or nucleus.
Yeah.
So we can kind of correct the firing and the overall output from that circuit to correct the function.
Yeah.
So we're not necessarily treating the disease itself, but we are electrically changing the signals.
Yeah.
One of the other uses for DBS that has been recently approved by the FDA is deep brain stimulation for epilepsy, which is another tool that we can use to treat patients with intractable epilepsy.
You were in residency and you're training for a very long time, and you've been practicing for a few years now outside of that. And just in that maybe not quite 20-year process, I'd imagine a lot of that stuff was happening while you were training. So, I mean, I remember when I was a kid, them talking about brain mapping. So like finding out, oh, the frontal cortex controls this and all that stuff.
Yes.
And now we're talking about going in there and changing, maybe this isn't the right terminology, but changing the wiring of that movement cortex so that you don't shake anymore. Or so that to me is amazing that in that 20-year period, or perhaps less, that much innovation has happened. Are there any other innovations that has like stood out to you?
So the role of focused ultrasound is more in the lesioning perspective, where a lesion is basically, you create a lesion is that you kill that area.
Right.
That is causing a problem. Or if you want a lesion, like burn a tumor or something. So you can do the lesion with different ways. We're using radiofrequency, using gamma knife, which is radiation, using ultrasound, among us other things. Now, focused ultrasound has the potential to be used to modulate the function. So if you go focused ultrasound, what it does is that it heats up the tissues. But there's a way where if you don't go all the way up with the energy and if you vary the frequency a little bit, then you can change how that ultrasound affects the tissue function without actually causing a permanent lesion. So that is another thing that is being looked at in focused ultrasound, is how to modulate different functions. We've seen experiments where applying a certain amount of ultrasound energy and frequency to a specific area of the brain, you can get a mouse to move its tail, basically. So is that going to be the future for controlling brain function using ultrasound waves from the outside? There's also the looking at magnetic simulation, transcranial magnetic simulation to alter the different signals, because we know that electric waves have a magnetic field, right? So if you change the magnetic field, will you be able to alter the electric waves and hence alter the function.
Right.
So that's all in its infancy, and the potential is huge to be able to do this without surgery, basically from outside the skull.
That's amazing. Because I mean, and if you look back at medicine 50 years ago, it looks a little like, wow, we used to do that.
Yes.
So I just wonder what new things will happen in 20 years where we'll look back at this time period and be like, wow, we used to go in there and like burn things off.
Yes.
And I mean, don't get me wrong, where we are now is amazing. I wouldn't trade 2000s healthcare for what we have now.
That is correct.
But that sort of stuff is amazing to me.
That is correct. So when we look at it from, for example, psychosurgery. So psychosurgery is banned, I think, in two states, in California and I think in Oregon. I'm not sure, but it's banned in at least 2 states because of what happened in the 1950s and 60s, where were going around and doing lobotomies and so forth.
Yeah.
Now we've come a long way from that. Where now we can do deep brain stimulation, which is reversible, very minimally invasive. You can turn it off. You can actually take it out and do psychosurgery in a very safe and ethical way, as opposed to how it was done 60 years ago.
Yeah, we're not talking lobotomies here.
Yes, right.
That's amazing. So I'd imagine, you've mentioned you had somewhere close to 30 mentors. And I'd imagine that you, having been a part of so many people's lives and them helping shape your life, that you sort of love giving back and helping mentor those people who are coming up behind you. So I'd like to close with the question of, what advice do you have for those who are coming up behind you? So in those mentor-mentee relationships.
Yes. I'm certainly passionate about education and teaching. And one of the main reasons I took the job here at Hartford Hospital is that we're starting our own neurosurgery residency in a few months.
Okay.
So that's definitely part of the passion that I have, that's included with helping other people, is teaching. And it's a principle that I tell my patients, is that I don't treat images. I don't treat the MRI or the CT scan.
Sure.
I don't treat the lab results. I treat you as a patient. So I like to spend more time with my patients, listening to them, hearing what they have to say, spend more time examining them, trying to get the full picture of what is really bothering this patient, not what is wrong with the MRI.
Right. So
the goals of the treatment have to be centered around the patient's expectations, the patient's background, the patient's life. And the clinical skills that come with that is not necessarily what is interpreted on an MRI or a CT scan. It's actually digging deeper and personalizing the care for every patient.
Right.
And I think that way you can impact your patients' lives in a much better way, rather than rubber stamping a certain treatment for everyone or for a subset of patients. And the other thing that I like to tell people who are thinking about getting to medicine, please don't get into medicine for money, because no one can pay you enough to do what you're doing. The risks that we take and the stress that comes with it, and it's not worth it if that's what you're doing it for. There are much easier ways to make money than this. This is the most stupid way to make money if that's what you want to do.
Sure.
Definitely do this because you want to help people.
Right.
Definitely do this because you're passionate about that specialty that you're choosing.
Well, Dr. Khaled, thank you so much for joining us here on the podcast. We really appreciate it.
My pleasure. Thank you for having me.
Thank you so much.